Your patient just rolled up from the PACU after a total thyroidectomy. While their vitals are stable for now, you have only minutes to organize the bedside before a potential rapid deterioration occurs. Following protocol, you must verify 4 critical items are immediately available: a tracheostomy tray, functioning suction, oxygen, and IV calcium gluconate. The head of the bed stays in a semi-Fowler's position, with the head and neck supported to prevent extension. Elevating the head minimizes surgical site edema and keeps the airway patent. These preparations serve as your foundational defense, buying critical seconds if an airway emergency develops. 2 hours into the shift, your patient complains that their neck feels tight. You inspect the surgical site, but the dressing on the front of the neck is perfectly clean and dry. Because gravity pulls blood toward the base of the neck, a clean anterior dressing can be deceptive. You must check the bed pad behind the patient for pooling. If blood accumulates internally, the pressure pushes against the trachea, eventually completely obstructing the airway. You have to distinguish between different sounds. Mild hoarseness is a common finding that suggests recurrent laryngeal nerve irritation, but stridor, that high-pitched wheezing sound, means the airway is actively collapsing. If you hear stridor in a post-thyroidectomy patient, what is your absolute first nursing action? You must immediately call a rapid response, open the bedside tracheostomy tray, and prepare for an emergency surgical airway. In a different scenario, the airway is secure, but the patient reports numbness in their fingertips and a tingling sensation around their mouth. This goes back to the anatomy of the surgery. The 4 tiny parathyroid glands are physically attached to the back of the thyroid. During the procedure, they are frequently damaged, removed, or lose their blood supply. When these glands stop functioning, serum calcium levels drop rapidly. This leads to hypocalcemia, which first presents as circumoral paresthesia, or tingling around the mouth. As the section on hypocalcemia and tetany notes, you must monitor for carpopedal spasms and use assessments like Chvostek's sign, tapping the cheek to check for a facial twitch, to identify escalating neuromuscular irritability. These sensations mean you must immediately administer the IV calcium gluconate you prepared during room setup. Providing calcium now stops the progression toward laryngeal spasms and seizures. Imagine you are the charge nurse receiving report on 4 post-thyroidectomy patients. You need to determine which patient requires your immediate attention. Patient A has minor hoarseness. Patient B is in the correct semi-Fowler's position. Patient D reports a pain level of 4 out of 10. These are all stable or expected findings that do not require emergency intervention. The critical patient is patient C, who is exhibiting frequent, continuous swallowing. Frequent swallowing indicates that blood from an internal surgical hemorrhage is trickling down the back of the patient's throat. This reflex tells you the patient is bleeding internally and needs to be stabilized immediately. To master post-op care, remember this framework. Airway is king. Always check the back of the neck for hidden bleeds. Monitor the laryngeal nerves for hoarseness, and treat calcium drops the moment